Next lecture, which is vascular emergencies. As I mentioned, we have three topics: acute limb ischemia, triple A, and carotid artery disease. So acute limb ischemia. So acute limb ischemia is different from what I gave you just now, اللي هي peripheral artery disease. Peripheral artery disease is a chronic disease, not acute. It's a chronic, will lead to either claudication, chronic limb ischemia, or an advanced stage will lead to critical limb ischemia, but not acute. Acute is different. It's something, the pathophysiology is different. It's something happening acute, quickly, suddenly. So it's a sudden decrease in the limb perfusion, causing potential threat to the limb viability. So acute arterial occlusion, sudden decrease in the blood supply. طيب, what are the cause of this problem? So what is the mechanism? احنا عندنا occlusion. So what are the causes? So we have multiple, I categorize them in three, انسوا الأخيرة هذه dissection. So three main causes اللي هي arterial embolism, arterial thrombosis, and arterial injury or trauma. So what is the difference between embolus and thrombus, or embolism and thrombosis? Embolism means that there is a clot or thrombus came in and occlude the artery from far away, from different source. Thrombosis معناته في thrombus formed at the same site of occlusion. يعني لما يصير عندي occlusion of the common femoral artery, so أقول هذه thrombus لما تكون الثرومبس هذه formed at the same site في الفيمورال، وأقول هذه embolus لما تكون الثرومبس هذه جاية من بعيد. So the most common one is actually embolism, and the most common source of embolism is heart. Okay, and the most common disease of the heart causing this problem is atrial fibrillation. So we have to remember this very well. So the most common source of embolism, most common cause of acute limb ischemia is embolism. Most common source of the embolism is heart. Okay, and the most common disease in the heart causing this issue is atrial fibrillation. طبعا 80% of it's from the heart. طبعا ايش عندنا, is there any other cause in the or pathology in the heart causing this problem? Yes, MI, infective endocarditis, most of the valvular disease, any other form of arrhythmias, atrial myxoma, ventricular aneurysm. A lot of heart disease can cause this problem. And sometimes non-cardiac in 10%, like what? Other source? Like large proximal arteries, like abdominal aorta or thoracic aorta. لما يكون في disease like aneurysm or dissection, sometimes لما يصير في aneurysm في الأورطة, it's a large vessel, يكون فيه thrombus in the wall. So sometimes piece of this thrombus dislodge and emboli cause acute ischemia. So this is the embolus. لما نجي على الثرومبوسيس, as we see here in the embolus, there is completely occlusion of the artery. ما نشوف collaterals, ما نشوف أي شيء لأنها acute limb ischemia. الارتري ما في. With chronic limb ischemia لما يكون عندنا peripheral artery disease, you will see collaterals, right? Here nothing. طبعا the most common site of occlusion هي الfemoral arteries. Then we go for the second cause, which is thrombosis. Thrombosis means, as I mentioned, formation of a thrombus as the same site of occlusion. عشان نتذكر the causes of thrombosis, usually remember the pathophysiology, the Virchow triad, اللي هي triad of thrombosis, either where vein or artery, اللي هي stasis, hypercoagulable status, and endothelial injury. So any of these can cause thrombosis of the vein or the artery or anywhere in the body, right? So stasis like what? Stasis like, for example, vasculitis, inflammation of the artery making stasis and then thrombosis. Stasis also like what? Like compression of the artery from outside externally, like by large lymph node or tumor. يصير في compression في artery. And then stasis, stenosis and stasis from outside. يصير في stasis في المكان, يصير في thrombus. So this is an example of stasis. نجي على hypercoagulable status, we have a lot of hypercoagulable disease can cause this problem. Like for example, antiphospholipid syndrome. With hypercoagulable disease, طبعا most commonly it affects the vein, يصير عندنا DVT, but also it might affect the artery, يكون عندنا acute limb ischemia. Okay. نجي على third cause اللي هي endothelial injury, like what? Iatrogenic injury. For example, patients going for cardiac cath through femoral artery. Usually there will be no problem, but sometimes يكون في injury في endothelium in the intima at the access site in the femoral artery, end up with thrombosis of the femoral artery and occlusion. So these are the causes of thrombosis. Some of the patient هذا اللي ابغاكم تتذكرونه وركزوا معاي. Some of the patients اللي يصير عندهم thrombosis كويس يكون عندهم chronic disease. مين هم؟ اللي في patients يكون عندهم peripheral artery disease with atherosclerotic plaque and stenosis of the artery. Suddenly يكون في rupture of the plaque and formation of a thrombus in top of that chronic plaque causing occlusion of the artery instead of stenosis. هذول هم الجزء الوحيد اللي يكون عندهم chronic disease صار عندهم الحين acute disease فنسميهم acute on top of chronic. واضح؟ هذول مختلفين. هذول they present even with less severe pain and less severe clinical features. ليش؟ لأنه أصلاً they have chronic disease before ischemia وعندهم collaterals, right? So their presentation will be different, will be even confusing for you and for themselves. فما يجونك على طول على المستشفى with pain within 1 or 2 hours و severe pain. لا، يجيك بعد يوم يومين يقول والله البين عندي من زمان بس زاد علي. هذول الجزء اللي عندهم chronic disease صار عندهم acute disease هم يدخلون تحت مظلة أو تحت الكاتيجوري of thrombosis لأنه كان عندهم atherosclerotic plaque and then rupture of the plaque and thrombus on top of that plaque. واضح؟ Then before I forget the third cause اللي قلناه من البداية اللي هو trauma or injury. Trauma, that means there is a complete transection or penetrating of the artery and there's no flow to the leg. So what an acute limb ischemia or blunt injury to the artery, not penetrating blunt. لما يصير في عندنا blunt injury, big hit to the artery cause dissection of the intima with part of the media فيصير عندي dissected flap تمنع الفلو. واضح؟ طبعا هذا التيبل ما هو مهم جدا بس يوريك الفرق بين الامبولس والثرومبس. الثرومبس only in those who had chronic. لا don't confuse yourself. اوكي الثرومبوسز اللي هنا في التيبل هو يقصد الثرومبوسز للناس اللي كان عندهم chronic disease, not thrombosis of patient has normal arteries زي اللي عنده antiphospholipid syndrome. واضح؟ يعني يقول لك اللي عندهم thrombosis on top of chronic يكون عندهم previous complication اللي عندهم embolus only no previous history يكون هذول عندهم long history هذول sudden onset. فهذا difference between thrombosis للناس اللي عندهم chronic disease and embolus للناس اللي ما عندهم ولا شيء. زي برضو ما انتم شايفين في الانجيو هذا on the left side this is acute limb ischemia secondary to acute embolus. So احنا شايفين ال left common iliac artery completely مختفي, completely occluded and there is no collaterals. The right side of the screen there is acute thrombosis on top of chronic disease لأنه في multiple collaterals هنا. واضح طبعا there is no left iliac artery but there is tons of collaterals. طبعا قبل ما نقول severity of ischemia remember that the features of ischemia اللي هي 6 P's اللي هي pain, pallor, pulseless, بيكونوثيرميا يعني cold limb and then paresthesia and then paralysis. So with the mild يكون عندهم pain, pallor, picothermia only. Moderate يكون عندهم paresthesia يبدأ sensory loss and little motor loss. with severe يصير عندهم complete paralysis. طبعا management you have to start the patient immediately into an anticoagulation. Anticoagulation will not treat the problem but will stop the progression of the thrombosis لأنه thrombus لما تكون موجودة أو الامبولس it will progress more and more and more. So you have to start patient immediately on IV heparin and you have to do revascularization immediately with either open or endo. Usually we do open, just open thrombectomy, we remove the thrombus. Endovascular is limited here because it's a fresh thrombus. We cannot do a balloon or stent. It's not a plaque, it's a thrombus. The only thing that we can do is a thrombolysis through the catheter. So as I mentioned, systemic anticoagulation is a must, and then revascularization with embolectomy or catheter direct thrombolysis endovascular. زي ما انتم شايفين هنا just simple hand draw on the skin, the anatomy of the femoral artery. This is inguinal ligament. هنا فتحنا ال femoral artery, superficial common femoral, superficial femoral, profunda femoris. Then we open the artery, arteriotomy. There is a clot here. We pass something called Fugati catheter, thrombectomy catheter. هو we pass it in, then we inflate the balloon, بعدين نسحب يطلع الثرومبس معاه زي ما انتم شايفين هنا. We pass the Fugati catheter, and then after removing the clot there is a flow now, very nice. Then we close the artery. طبعا thrombolytic agent we use TBA, usually catheter direct thrombolysis. Also there is something called percutaneous mechanical thrombectomy we can use as well. Now, this is very important complication of acute limb ischemia. طبعا there are a lot of complications, but I'm talking about the complications are specific after revascularization. Okay, so you have to remember these اللي هي compartment syndrome, ischemic reperfusion syndrome, and rhabdomyolysis. Sorry. So what is ischemic reperfusion syndrome? So the leg is ischemic for a long time. So when the leg is ischemic, there will be a lot of toxins accumulate in the leg, including potassium, lactic acid, myoglobin. So when the blood flow restarted again, the arterial flow restarted again. So all of these toxins will come back in the venous system, in the washout, will go back to the body. So the body will be affected by hyperkalemia, metabolic acidosis, myoglobinuria. So you have to be careful and watch all of these things because it's dangerous. So this is simply the ischemic reperfusion syndrome. Before the compartment, we go for the rhabdomyolysis, which is some sort part of the reperfusion syndrome, but لأنها مهمة حطيناها لحالها. So what is rhabdomyolysis? Also, with the long time of ischemia, so the muscular cell or the muscle cell will destroy and destruct that down, and the myoglobin will accumulate in the leg. After restarting the blood flow, the arterial flow, all of this myoglobin will go back to the body through the venous system. So the myoglobin will affect the kidneys. It will affect the tubules of the kidney and cause a necrosis of the tubule and end up with acute kidney injury. So after revascularization, we have to watch the creatinine, the kidney function of the patient. We have to watch the urine output. And also we have to watch the color of the urine, because with the rhabdomyolysis, the color will be dark or red, and treat it with hydration and alkalizing urine. When we go back to the third one, which is compartment syndrome, what is compartment syndrome? It's increase in the compartmental pressure. As you know, in the leg, we have 4 compartments: lateral, anterior, deep posterior, and superficial posterior. Each compartment has muscle, nerves, veins, arteries, and surrounded by what? By a layer of fascia, which is not stretchable at all. So compartment syndrome increase in the compartmental pressure. It can be caused by either reperfusion or other causes ما لها علاقة في الفاسكولار حتى زي fracture وتروما إلى آخره. So the usual pressure or the normal pressure of the leg compartment, it's up 10 to 12, might go to 15 with exercise. But if it's more than 25 millimeter mercury, that means that there is a problem. So you have to treat. What is the problem? What will happen here? That after reperfusion, again, the leg is ischemic for a long time. After reperfusion, all of this, the swollen, the muscle in the leg will be swollen immediately. The muscular cell will be swollen. The permeability of the cell will increase. There will be also edema or fluid in the interstitial space. So the muscle حتكون very, very swollen, and there is no space for expansion, because the leg, the compartment is surrounded by the fascia. So what will happen? The muscle will be started to get necrosis, from outside at the level of, not inside, from the outer layer of the muscle, we started to get necrosis at the level of what? Of the capillaries, لأنه حيكون في compression على muscles. So all of the blood flow in the muscle capillaries and arteriole will be compressed, حيكون في necrosis. But not the artery itself. الtibial arteries اللي ماشية في compartments will not be affected لأنه the pressure in the artery is higher than the compartmental pressure. So the pulse will be there. لما تيجي الواحد عنده compartment syndrome وتشيك على dorsalis pedis or posterior tibial, it will be there. It's not a part of the clinical feature of the compartment syndrome. Clinical feature of compartment syndrome is pain out of proportion, very severe pain, and very swollen and tense leg. واضح? So the treatment is fasciotomy. We cut the fascia to release the muscle. Usually we do it prophylactically if the leg was ischemic for a long time. Any question about the acute limb ischemia? So then we go for the aneurysm. This is the first time that you take it. So what is the definition of aneurysm? You have to know that in your career, in your future. So حتى لو ما كنت vascular surgeon. So aneurysm anywhere in the body means that enlargement of the artery more than 50% of the normal size. This is very important definition. يعني لما تكون واحد منكم راديولوجيست قاعد على سي تي سكان يبغى يقرا سي تي ويشوف والله الرايت فيمورال ارتري اكبر من الليفت فيمورال ارتري، متى اقول هذا انيوريزمال متى ما اقول انيوريزمال؟ So you have to check the normal size. So for example, if the normal size of the femoral artery is 1 centimeter وانت اللي قسته 1.3, so I will not say aneurysmal femoral artery, I will say enlarged or ectatic femoral artery. If it's 1.5 and more, I will say aneurysmal artery. وهلم جرى يعني it's 50% more than the normal size. Sorry. طبعا the most affected part، ايش most affected artery in the body اللي هو الأورطة 90 to 95%. Especially where? Infrarenal abdominal aorta. I want you to say infrarenal. aorta عندنا الأورطة يطلع من الهارت إلى البايفوركيشن تحت. عندي ascending, arch, descending, abdominal. الابدومينال يبدأ من الدايفرام إلى البايفوركيشن. الابدومينال aorta في عندي infrarenal، في عندي suprarenal، في عندي supraceliac. So specifically infrarenal abdominal aorta. طبعا the true, I'm talking just about the true aneurysm, which is affecting the whole layer, the 3 layers of the artery. Okay, there is something called false aneurysm. عشان بس تعرفون الديفينيشن حقه is different story. False aneurysm is usually is disruption of the arterial wall with the presence of the blood flow outside the normal layer, ويصير عندي a capsule of fibrous tissue around it. يعني is not aneurysm of the artery itself, is like puncture of the artery with continuous flow, and then a tissue are surrounding that puncture or that hole, causing semi-aneurysm or sac. It's not aneurysm. So etiology of the aneurysm, especially abdominal aortic aneurysm, there are a lot of etiologies. I'm concentrating here on the degenerative, which is the most common one. So degenerative, the most common, is a complex process, involves some degree of calcification, atherosclerotic pathology, degenerative, and MMPs. طبعا كل هذه نظريات. Until this time, nobody knows exactly what's happening and what is the cause of the degenerative aneurysm. Degenerative aneurysm is the aneurysm that the most common and affected the most elderly people or those has family history and silence. So especially in the West. So في نظريات كثيرة. بعضها يقول لك affected by atherosclerosis, بعضها يقول لك by the collagen, بعضها by calcification. So a lot of theories. Other causes of aneurysms like inflammatory disease, infection, congenital, connective tissue disease, trauma، كل هذه الأشياء تسوي لنا aneurysms. But the most common is the degenerative. هذا هو اللي بنتكلم عن التريتمنت حقه بعد شوي. So risk factors, when I say risk factors, هذا risk factor of the degenerative, the most common one. طبعا old age 65 and plus, male to female 4 to 1, so male are more common. White race, especially in the West. Positive family history, very, very important. Smoking, hypertension, hyperlipidemia, peripheral disease, coronary disease. Okay, so patients with degenerative aneurysm or aneurysm, usually there is, gradual expansion of the aneurysm about 0.3 to 0.5 centimeter per year. A complication that might happen اللي هي rupture or thromboembolic event زي ما شرحنا في acute limb ischemia or compression. When risk of rupture, if this aneurysm, again I'm talking about the infrarenal abdominal aneurysm. So if the aneurysm is less than 5 centimeter, the risk of rupture is low, less than 5%. But if it's more than 5 centimeter, the risk of rupture يبدأ يتضاعف بسرعة. 5 to 6 centimeter 10% per year, 6 to 7 centimeter up to 20% per year, then above 7 up to 70% per year. So that's why احنا نختار السايز هذا اللي هو السايز indicated for treatment اللي حنقولها بعد شوي. So presentation asymptomatic, which is the most common. So لما أسألك أقول لك what is the most common clinical feature of AAA تقول لي incidental findings. So the most common يعني presentation اللي هم referral from other specialty to us after incidental finding of AAA either by CT scan or ultrasound done for any other reason, so gynae, GI, GS, whatever. Urology or symptomatic يكون عندهم abdominal or back pain due to طبعا leak or rapid expansion، أو يكون في compression symptoms or obstructive symptoms، أو يكون في rupture. طبعا the physical examination is not very sensitive, to be honest with you. But if the patient is very thin, you can feel pulsatile abdominal mass. Ultrasound is very highly sensitive. It can be detected by ultrasound only or CT scan طبعا, especially CT angiogram. This slide is very important. طبعا لما يكون patient جاني عندي في المريض في العيادة عنده AAA، والله يحولوني والله اليورولوجي ولا الجي اس عليك، أنا ما أعرف إيش فيني، ما فيني إلا العافية. So you have to explain to the patient that what is the disease. So it's عبارة عن تقول له عبارة عن expansion or ballooning of your abdominal aorta, and our aim here is to prevent rupture and death. So how to prevent rupture and death, inshallah, to follow up the patient with some sort of imaging, either ultrasound or CT scan, كويس, until there is an indication for surgery. What are the indications of surgery? Here 4 indications. Number 1 اللي هي size 5 centimeter in female, 5.5 centimeter in male. طبعا you can say just 5.5 وخلاص عشان ما تخربط نفسك. So لما يوصل 5.5 centimeter, so I have to be regardless there is symptoms or no symptoms. Okay, why? Because the risk of rupture now is higher than the risk of surgery. And we wait because surgery has a risk, right? So and the risk of rupture below 5 centimeter is very low. So when it's reached 5.5 centimeter, معناته إنه the risk of rupture is higher than the risk of surgery, so I have to do the surgery. 2, symptomatic. Any symptoms, even if the size is less than 5.5. Okay, symptoms including what? Abdominal pain, back pain, obstructive symptoms. Obstructive symptoms including what? طبعا very rare, but it can happen. That's been إنه aneurysm causing compression على واحد من ال adjacent or closer organs, like what? Compression over the ureter ممكن يسوي لي hydronephrosis. Compression over the iliac vein or IVC ممكن يعمل لي DVT. Compression over the bowel ممكن يعمل لي bowel obstruction. So كل هذه اسمها compressive symptoms. Rupture طبعا any rupture you have to repair, or rapid expansion. During the follow-up, usually as I mentioned in the beginning, so the expansion usually between zero point 0.3 and 0.5 centimeter per year. هذا natural history. So if I see the expansion is very rapid, for example, 0.5 centimeter every 6 months or 1 centimeter per year, even if it's still not 5.5, I have to repair. واضح? These are the 4 indications for treatment. طبعا surgical repair treatment either surgical اللي هو open surgery or endovascular with EVAR. Open surgery, as we see here, we open the abdomen and then we open the aorta after clamping, and then we just repair the graft with suture, or endovascular through the femoral artery. We go up and put a stent. The stent gets attached from inside to the normal aorta and to the iliac below. So we exclude the aneurysm. Rupture AAA طبعا most of those people أصلا ما يكونوا يعرفوا, they don't know that they have this problem. Unfortunately, the mortality after rupture is very, very, very high. 50% of those get ruptured, they don't arrive to the hospital alive. And 50% of those arriving alive, they die in the hospital. So the mortality rate is very, very high. So usually they come with a severe pain, abdominal or back pain, and then started to get hypovolemic shock or hemorrhagic shock, tachycardia, hypotension, and then loss of consciousness. So treatment, ABC, airway, breathing, circulation, 2 big IV lines, start the blood transfusion, call the vascular surgeon, send the patient to the operating room for repair. Any question? Then I'm starting to talk about the carotid artery disease. Again, take it simple. Carotid artery disease, same as any atherosclerotic disease in the body, same as peripheral artery disease or coronary artery disease, عبارة عن atherosclerosis of the internal carotid artery. As we see in the picture, there is atherosclerotic plaque at the proximal part of the carotid artery, causing stenosis of the internal carotid. The only difference between the carotid artery disease and coronary artery disease and peripheral artery disease, that in peripheral artery disease or coronary artery disease, the mechanism, what is the mechanism? What will happen? There will be atherosclerotic plaque causing stenosis and then decrease in the blood flow, which will lead to ischemia, right? Whereas in the carotid artery disease, same thing happening, but the brain is a very well rich organ. There are 2 internal carotid artery and there are 2 vertebral arteries, and there is in between circle of wells in the brain. So if there is a stenosis or occlusion in one of the carotid, usually there will be no ischemia secondary to the decrease of the blood flow because the blood will come from other arteries. But what will happen is that usually the internal carotid plaque is very nasty, soft plaque. كويس. It's different from peripheral artery plaque or coronary artery plaque. They are very calcified. But here in the internal carotid usually is very soft. So piece of this plaque might go up and shower with the blood flow and shower and close one of the small arteries in the brain and causing the stroke or TIA or whatever. واضح؟ So هذا الفرق بين ال peripheral artery disease والcoronary artery disease والcarotid artery disease. هي نفس الديزيز، نفس الريسك فاكتورز، نفس العملية، لكن with the mechanism of the stroke or ischemia in the brain is not because of the decrease in the blood flow, is because of the showering of the piece of the plaque up to one of the brain vessels. Risk factor exactly same as peripheral artery disease اللي هي modifiable. Clinical presentation either طبعا asymptomatic، كثير منهم asymptomatic. Sometimes we detect by routine examination like screening by cardiac surgery or family medicine, and some of them symptomatic. Some symptoms like what? Stroke or TIA or amaurosis fugax. What's the difference between stroke and TIA? عبارة عن the same. Neurological deficit less than 24 hours we call it TIA. If the neurological deficit more than 24 hours we call it stroke. Amaurosis fugax عبارة عن temporary loss of vision in one eye less than 24 hours. Investigation, again we have carotid duplex, which is non-invasive. We can get CT angiogram, MRA, or carotid angiogram. Any of these can diagnose the problem, but the most important one is the carotid duplex. Very, very important. Why? Because with the carotid duplex, we can know the stenosis of the internal carotid artery, and based on that stenosis or based on the stenosis percentage, we decide about the management, either medical or surgical. So if the stenosis by duplex less than 50 to 60%, so we only treat the patient medically with no surgery. There's a risk factor modification and best medical treatment اللي هي antiplatelet and statin, same as peripheral artery disease. If the stenosis is more than 60 to 70%, كويس, we do something called carotid endarterectomy or stenting. Carotid طبعا endarterectomy is the most important one, which means that you open the artery, you clean the plaque, and you close the artery, you patch it. طبعا this surgery is to prevent stroke, is not to treat the current stroke. So if the patient has a stroke which is resolving or TIA, you have to explain to the patient that you have a stenosis, which is indicated to do treatment because the risk of another stroke is very high. واضح؟ طبعا أنا أتكلم هنا عن السيمتوماتيك patient. الاسيمتوماتيك patient قصة ثانية ما لكم علاقة فيها. واضح؟ So if the stenosis is less than 60%, only medical management. And if the stenosis is more than 60%, I do carotid endarterectomy. هذا وين في symptomatic patient only. So simply carotid endarterectomy is just you open the carotid artery, you take out the whole plaque, and then you patch it and close it. طبعا there are some complications of this carotid endarterectomy, including stroke during the surgery itself or immediately after the surgery, because during the surgery you clamp the artery, you handle the artery. So there is a risk of stroke. That's why we don't do it if the percentage is low. واضح? We do it only if the risk of stroke without doing it is high, very high. واضح? So if the risk of stroke with carotid endarterectomy is lower than the risk of stroke without carotid endarterectomy, we do the surgery, and vice versa. So complication after carotid endarterectomy, patient can get stroke, cranial nerve injuries as well, because we are working in the neck. So there is a vagus nerve and hypoglossal nerve, glossopharyngeal nerve, especially hypoglossal and vagus, هذا close to the carotid. And we can get bleeding and hematoma. Also, this is dangerous because you are working in the neck. There is a hematoma, can cause airway obstruction. Restenosis, infection, MI, all of that can happen after carotid endarterectomy.